Well, it is really my pleasure to introduce our next presenter to you. This is Dr. Liliana Oakes, and she obtained her degree in medicine from the National University of Columbia, and then she did her residency and her geriatric fellowship here at the University of Texas Health Science Center in San Antonio, and that was in the family and community medicine and also geriatric medicine. There's much to say about her. She's involved in so many things and activities and projects and research and publications, but I think the most important thing is that she's a wonderful doctor and someone I would choose for my family member, and she's going to talk with us today about geriatric assessment. So please welcome Dr. Oakes.
Thank you very much. That's the best presentation I ever hear. And somebody said that they recommend their mom to me. I think that's a good place to be, right? Well, welcome everybody. I have been here several times. I was very, very pregnant 2 years ago, so I couldn't do it. And my colleague, Dr. Rose, was giving this lecture. Everybody getting hungry. I know it's close to noon time. So we're going to have fun together. This is a session that hopefully will reach the heart of each one of you and your individual needs as a professional. And what I'm going to give you is going to be actually a lot of participation. So the more that you can do and the more that you can get out of this by doing it and sharing your ideas and your expertise, the best. I'm going to be talking a lot of, in a summary of a lot of things that you have here in the past couple of days and putting those in a context. And then I'm going to make more emphasis in the actual evaluation that we do in our offices. And simple things that you actually can do if you need to encounter an elderly patient, and at least being aware of those things that can help you to improve your practices. I just wanted to know, and raise your hands, we have people from the APS here today. If you're from APS, I wanted to know, who are you? Very good. We have also nurses. Who are you, the nurses? Wow, a lot of nurses, wonderful, welcome. Or fellows, I know my fellows here, so that's great. And dental, people from dental area. Any physicians, primary cares today here? Anybody else that I didn't mention? So, dietitian, yeah. Wonderful, welcome. Okay, so we have an interdisciplinary approach, and what I love about this topic is that's what I do for a living every day, work with all of you and pick your brains, and that's one of the things about geriatric assessments today is the work that all of us do for our patient. And what you do is equally important as what the physician does, because that's your area of expertise. So this is what a geriatric assessment is. So let us start here. And I want that you tell me when I'm going to be moving a lot. Is that a problem? Okay, you're going to be busy. Good. Geriatric assessment, what kind of things come to your minds when you hear the word geriatric assessment?
Go slowly.
So go slowly. Can you elaborate on that, please?
Sometimes we have to think a little bit about what the question is and then think some more about what the answer is.
Okay. So geriatric assessment is asking a lot of questions and really hear what the patient is saying. Did I understand that correctly? Very good. So it's a place or a circumstance where you need to interact a lot and hopefully gather a lot of information. Very good. What else is geriatric assessment? Okay, so be sure that they are able, and you have learned in the past 2 days about capacity and cognition. Can they really engage and give you the information and what's going on? Very good. What else could be geriatric assessment? Respect. Okay.
Their wishes and their feelings.
So very patient-centered, right? It's trying to gather information around a patient-centered approach where we need to understand where this patient is coming, and that includes culture, includes language, includes family. So all of you are saying a lot of wonderful things. It's much more complex than what we think. Very good. What else could be geriatric assessment?
Function.
Very good. I think I always tell this to everyone that I met in when I teach in my clinic. Remember the F word in geriatrics. Not the bad one, but the good one. Function, function, function. Everything we do in geriatrics, the major goal is to preserve function in an older person. So I tell my trainees, if you don't know anything about geriatrics, but you are smart enough to think about function, all your answers are going to be right. Because we're not here, we don't see patients as diseases, we see people that are very complex, human being in an environment and a family that wanted and did multiple things, and you wanted to preserve all of those wishes. Even if you're very demented, preserving dignity, respect in their own level. You know, but function, even if it's very little, and of course the caregiver. That's the other beautiful thing about geriatrics. You always need to think about the family and the caregiver. Very good. All of those questions are great. So I'm going to give you the interesting things. We're going to be talking about the geriatric assessment, the functional status, and why we do all of these that we do. So let us move to the definition, a little bit of history. There was a wonderful physician called Marjorie Warren in the 1930s. This woman was in England, and in those days, everyone that lose function and look crazy, now we call that dementia, we know that is dementia, were institutionalized. So she went to work in these infirmaries in England, and she said this is not possible, that all of these human beings are institutionalized, and we're not doing anything to improve quality of care. So what she started doing is implementing systematically tools to really see which kind of areas in these individuals you could rehab, you could improve because maybe it was depression, and systematically she started applying a lot of tools individually in these patients, and many of them were able to go back home to their communities, and many of them stay there but with a different perspective. And we consider Marjorie Warren the mother of the geriatric assessments in geriatrics. So the critical words here are systematically and evaluation and interdisciplinary approach. We need to do something to help them to get out of this. So this is the fancy definition. It's a multidimensional, often needs to be interdisciplinary, so all of you need to participate in the care and your expertises. Diagnostic process intended to determine a frail elderly person's, and I love this part, the medical, the psychosocial, and the functional capabilities. To do what? To do a very systematic process of care of plan so you can long-term address the needs in the different areas and improve the care of these people and hopefully preserve dignity and get them out of their problems where they have. So you say, wow, this is overwhelming, man. In a system of Medicare where you only have primary care doctors with 15 minutes, I am so glad I am not in the 15-minute deal. That's the reason I do geriatrics. I take longer with my patients, and I don't make a lot of money. But that doesn't matter. We do what is right, which is doing defense with them. So there are two types, just to tell you how a primary care doctor can do it. Because that's what we need to do. There are not enough geriatricians, so we are training people in our programs to do a very good geriatric care, even if it's in 20 minutes. And you could do that systematically. Let me show you how. There are two types. You can do the brief geriatric assessment, or you can go to the multidimensional. What we usually do is the multidimensional, but we don't do it in one visit. We usually take several visits. They are usually done sequentially and very often until we accomplish all of these tools and these evaluations. Usually in the brief is included what all the doctors do, which is a history of physical exam. We apply the instrumental activities of daily living and the ADL tools. We apply some cognitive evaluation that could be a combination of the mini-mental and usually the clocks. And we usually always determine how the patient affected status is. But not only that, over time we usually do everything in the brief, but we usually do a full risk assessment, and I'm going to show you today, if you haven't seen it, how we actually do it. We do the advanced directed inquiry, and you could do it in your practices by having a standard, and any new patient that comes have the advanced directives given to the family, so when the provider sees the patient, we get a reminder like, have you ever heard of advanced directives? You won't believe it, maybe you do if you work with Latinos. Many of my Latino patients never have heard about advanced directives. That's very American. I'm Colombian, and we don't talk about that stuff. Actually, it's bad if you talk about it. It took me 3 years to talk with my mom about, Mommy, something really bad happened to you when you want it. Hija, please don't say that, you know, you are going to, you know, something bad is going to happen. Culture. But we need to do it, and there are gentle ways to do it. And you need to know that when you have your relationship with your patients, when you see them over time, when there are opportunities where they are sick, you know, when there is a disease process, those are teachable moments where we can start advancing them to talk about that. So a Korean, a Colombian, and a Latino could go there. It's not impossible. It's an art. That's the reason this talk is about the art of dealing with older adults. We usually check hearing and vision because those are very neglected areas, and they are, you will see later on, culprits of many things that happen in elderly patients. And we usually do health maintenance intervention as part of the visits. If you are so sick today to see one of us, you probably are not going to move right away in the health maintenance. We need to deal with the other issues. But over time, we systematically in our clinics try to organize this in a way that all of those things get done so we can have a picture of this human being. Okay, so many of these tests are intended not only to address normal people, which we do, so we train our physicians to see normal patients, elderly people. I have a lot of my patients that are still playing golf, travel to China. They come for vaccinations because they do mission trips. They have children all over the world. I have a lady that has done a cruise for 27 days consecutively. We needed to spend a whole hour about all of the diseases where she was going to go. So I want my trainees to see those very healthy, you know, older people, 85, 90 years of age, preserving function. But then we have the frail ones that require more of this testing. So even though we apply this normal testing in a normal person just so we can teach how it looks, these testing are intended for people that are a little bit more frail. So let us talk about what frailty is. What came to your mind when you hear the word frail? Any volunteers on the back? Yes, ma'am.
High risk.
So high risk. Tell us a little bit more what you mean.
For falls or any adverse outcomes.
Okay. So these are people that get really sick and probably get complicated fast. Very good. What else?
The nutrition too.
The nutrition status. So frailty as a nutritionist, what will you say about that?
Because a lot of times they don't want to eat, or they don't feel like eating, or they don't have anybody to help them with healthy meal preparation, so they're going to go and grab a frozen dinner or something that's not going to really help to provide the nutrients that they need, that's important for the mental and also for the sense of well-being as well as the movement.
Absolutely.
The movement.
And you isolated, impoverished, high risk for adult outcomes. That's exactly how we mentioned here. High risk for illness, hospitalization. And if you don't do well, you think you're going to go back home? No, so that's terrible because then you need to start looking into it. They don't have family, nobody can care for them. We really need to institutionalize them. So really bad in terms of what can happen to them. They don't return home usually. And this is breaking the system. 25% of these Medicare patients account for 90% of the total Medicare cost. So from all the elderly, the more frail ones are using 90% of the resources. So there is a recent study that it's incredible the amount of money that people are using in the 4 last weeks of life when they are really frail. It's consuming tremendous amount of resources. ICUs, and that's the reason we're trying to look into really palliative care programs and more geriatric assessments and more interdisciplinary approach can move these families and patients to have dignity at the end of life instead of a lot of invasive workups that are not going to be appropriate for them. For a geriatrician and for you guys that deal with so many elderly patients, it's a more complex stuff. So we try to really bring elderly people to function as much as we can in the 3 spheres. We usually do the functional stuff in our review systems, and something that I really make emphasis with my learners in our clinic is all of our students are very used to talk about if you have nausea, vomiting, if you have weight loss. Beautiful, do that. But in geriatrics, you need to add always functional assessment in your review system. How much can you do at home, right? How much can you care for yourself? How much you can get out? Are you falling? Are you continent? So in the review system, a person that deals with geriatric population, primary care, a nurse, an APS person, needs to look into the review system as a little bit more complex, more geriatric part. Older people are not going to tell you spontaneously, hey, I have incontinence, I pee. Many of them believe that's normal. Hey, I'm getting old, and that's what happened with the abuelitos that are chochitos, they just pee in their pants, and you know. It's not a normal thing. Well, you fell. Well, I'm old. Maybe you suppose that you get a certain age and you fall. Those are abnormal things. So you need to ask those because many of the facial injuries that dentists deal with are a consequence of a fall. And you can put beautiful stuff in them out and they are continuing falling, they're going to come with a lot of damage to what you're doing. As a nurse, it's a big problem with JCO regulations in Medicare in hospitals right now. False program and fall assessment. Your patient fell at the hospital, they're not going to reimburse you. You have a pressure sore at the hospital that is new, they're not going to reimburse you. So this is hitting hard the dollars for hospitals, so people are doing a lot of prevention and a lot of programs and committees to address that issue. Okay, so let us look very briefly. Let's see how we're looking. We're looking good. How many of you have been sick to a condition where you lose your independence? Anybody here use glasses or contact lenses? Raise your hands. Oh, several people. What happened when you don't have your contact lenses or you forget your glasses?
I can see the board.
He is blind like me. Yeah, I just cannot function. What else?
I can drive.
Oh, driving.
I shouldn't drive.
Big issue. He shouldn't drive, but he does it. We're not going to cut it. Anybody else that wear contact lenses and have problems temporarily with contact lenses? Usually there is
Well, then
something.
you can't read the packaging, you can't
So you
read
can't
any
read.
directions or.
Pretty tough.
Frustrating.
Frustrating, very frustrating. I lost my glasses, had two little kids, and one of them decided to play hide and seek with me, so I hid the glasses, and it was very interesting for 2 hours trying to figure out where the glasses were. Very frustrating, you know, anxiety and all that stuff. How many of you have broken a bone? Which one? The clavicle. Okay. Recently, when you were little?
5 years.
5 years ago. Anybody else? Femurs? Usually there is somebody that plays football and breaks something. Fingers, toes? Only you. Okay. Can you work with me? Okay, so it was 5 years ago. How you broke your clavicle?
Fell downstairs.
You fell down the stairs. Wow. Can you share with us, did you trip over something? Did you feel dizzy?
I wasn't sure where the bathroom was. There
Okay.
were no night lights.
Mm.
I went out the wrong door.
Wow.
And to the left were stairs. I thought that was the bathroom.
Okay, so confusion, dark lights, and you felt, thank you for sharing that. How long were you in the sling, or did they put a figure of 8, or they put a sling?
I was incapacitated for about 4 months.
4 months. I'm going to work more personal questions, do you mind? Were you able to bathe yourself, or you
No.
needed help?
No.
How was that?
Embarrassing.
Mm-hmm.
Till I got a stranger.
Wow.
It was hard for my daughter to do that for me.
Sure. Thank you so much. You are the first person that actually is older enough to tell us from the heart. I usually have a young person and we joke around and everything. But in your case, what is your name?
Trish.
Trish, thank you for sharing. Because Trish just told me what you are going to, what I usually do is, imagine all of you with visual impairment, but you are 85 now. You are not just visually impaired at my age, you know, I'm 15, but you know, you are older. And what happened? And Trish, thank you for opening your heart, because that's exactly what happened with older adults. And I wanted to do this exercise because sometimes we forget how hard aging is. And when we need to depend on people, and sometimes it's not our loved ones, it's a stranger, maybe a provider, you know, maybe a friend at church. So disability is very painful emotionally and physically in an older adult. And it's really hard when you change an environment. I'm wondering if you maybe were in a place that is not familiar to you.
Yes.
So
New place.
it was a new place, and there is no light, and you are, you know, half awake, half asleep. So all disability and things that we do in the geriatric assessment are targeting to see how we don't go there, you know, how we can prevent that. And if we need to go there like Trish went, how we minimize it, right? 4 months was a long time. So thank you for sharing. Yes, ma'am.
I was taking a lady to church, she's 85, and she fell when she got out of my van, she stepped out, and she fell, and she bruised her knee and her elbow, so she hasn't been able to come back to church since last week, so I'm feeling very guilty because I think I should have been there to help her out and help her to stand, and there was a little hole somewhere in the grass that was uneven.
Sure.
So she
But you know, even in the best circumstances of care, people can fail. So I love that you recognize that maybe in the future for any older adult that you will deal, now you're going to think twice. But I'm telling you, there are things in progress where we are doing everything, people just fail. So sometimes they fail so much that it's not about failing, it's minimizing injury. And that's what we do when people fall and fall and fall, is minimize injury. You know, there are people that we have done everything and it's just the frailty so bad that then you just start looking into how we minimize the impact of the health. So you see that the difference. So sometimes it's great that we spend time in fall prevention programs. Everybody needs to be aware. This hopefully will help you. This week is phenomenal because you're going to get perspective from different people. But sometimes they just fail, you know. And so I'm glad you said what else we could have done. So let's see what other ideas we have here. Okay, so basically we're going to go over briefly a few things. I like this because imagine 3 circles. People have usually a personal dimension. They have a domestic dimension and they have a social dimension. So the personal dimension is what you did this morning before you came. You can shower at home, and you have a nice breakfast, and you transfer yourself, you toilet, you brush your teeth, you do stuff, you care for yourself. But then you also cook, and maybe you clean, you maybe change some diapers, or you maybe did some few things before you came this morning. That's your domestic thing. And then you were able to get into your car, maybe make a phone call, pay some bills, call a friend on the way here. That's your social dimension. Something that you need to know is people with cognitive decline usually lose things backwards as we learn it when we are babies. So the first thing that we do when we are babies is what?
Learn to recognize.
To recognize and to suck so we can eat. That's the last thing that a human being loses with age. So the first thing that an older adult start losing is their social dimension. They cannot pay bills, they get confused, the phone becomes really difficult to handle. And the last thing, they are progressing backwards until they cannot care for themselves. So when you see somebody in your disciplines that is already having personal care issues, and is not related with a physical limitation, we're talking about a more severe case, right? Than somebody that is still functioning, but they're having some problems with the finances, or maybe transportation, or they maybe couldn't find the store coming back, or they get lost. You know, there are red flags. So this is just to tell us that when we apply the testing, that's what we usually look. And did you already review the scales with somebody so far? Should I go very briefly and tell you what they are? Okay. So the ADLs and IDLs is like all of these people, the researchers said, you know what? We talk about personal care and domestic care and social care, but how we can talk with other people around the world so everybody has the same language. So they gave it the name of activities of daily living, and the references down there. And basically that scales that clinicians usually use to determine the degree of impairment in each one of those areas. That's what it is. So I'm going to go over with you and review them. So is the skill that you need to live independently is a great predictor of functional decline. That's the reason when you read the studies about dementia, you're going to see ADLs and IDLs. And when you read about Aricept or medications that slow down the dementia, they're going to show you these people was able to continue being tolerated. This person have few more weeks or years or whatever, or their personal care. So they mean something, right? There is an interpretation of what that is and help us to make decisions and interventions. So the personal care usually are related with your eating, bathing, tolerating, dressing, transferring, and continence, right? Very personal care. It's not only that you tell the patient, can you bathe, but how much you can bathe. Trish was able to be bathed, but with assistance. So Trish could say, yes, I was bathing, but I needed total assistance to do it. I just sit probably in the chair, in the bathtub, and they do clean. Some people will say, or, you know, I need assistance, but minimal. Somebody just looking for safety, right? Maybe a provider is standing up so when they get out of the shower. Or, no, doctor, I bathe myself, brush my hair, wash my hair in the, you know, with shampoo, don't have any problem, never fail. So it's not only that you address the activity of daily living, but how much? They really need to have it. So you have few examples. The bathing, you don't need assistance. You need assistance only with one part of the body. So maybe the person is able to bathe completely, but the back, they cannot reach anymore the back because of arthritis or kyphosis or something. You wanted to know the degree because as a clinician or as a professional helping these elderly patients, you need to know how much you need to address them. And if somebody is requiring a lot of care, well, the resources need to be changed. We need to advise families to get different care, or we're talking about institutionalization. Yes, ma'am.
Along that line, I think it's really important that when we people are in such a hurry, it's just easier for me to do it. But what you're doing is not letting them continue to function, even if it's a little bit of what they can do. And I mean, even if you have to be creative to let these people be independent in some way, you need to work to do that. And I think so many times we're in a hurry, we don't remember that.
Exactly. Yeah, you're talking from a lot of caregiver perspective, right? That's what my research is about, is Latino caregivers, and we train them, and we have sessions where we talk about this. And I think there is a balance. There are circumstances where you need to go to a doctor's appointment, and the caregiver needs to do a lot for them. But if you have the time and the routines, allowing them to have control over a few things and choices will make a difference in terms of their dignity. So many of you, probably you have a busy physician, but you love the elderly and you have the training, you could do that with them, and work with them, and address those issues with the caregiver, and balance and negotiate on how much you can do. The instrumental activities of daily living is what we talk about, the social dimension, the thing that make you to reach the outside. So include heavy housework, laundry, housekeeping, going to errands, transportation, telephoning, preparing the meals, and again, the degree, and we go back to our dietitian, how much are they getting meet their needs in terms of nutritional status? Can they prepare all the meals? Like I usually ask my families when they come to the initial visit, when was the last time your mom was able to cook a big Thanksgiving meal? And if they said, well, probably 5 years ago, then I start asking more questions, because that's a big task, and if you could do that, you are pretty good here, right? But when you are only buying frozen foods, or then you stop even buying frozen food because you cannot operate the microwave, we can look into more difficult patients. So again, the degree, see, few questions. You don't need to spend a lot of time. It's just few questions, and your interviews, what you're doing, regardless of your specialty, are very helpful. Many of you actually come sometimes and say, Dr. Rose, I just talked to the patient, and actually the relative was telling me that she's not doing this or that, which is a very important point. You always need a third person confirming information. So all my patients that come, I need to ask permission to the patient to ask a relative, daughter, child, husband, somebody that I can make a phone call that is cognitively intact. Say, this is a routine, your mom came here, or your dad came here, this is what we found, can you tell me? Do you agree? Sometimes there are huge discrepancies in the information. So you always need a third party to confirm information. I'm doing great, wonderful, and then you find out they are not doing great or wonderful. So again, having in geriatrics somebody that can provide that information helps. This is a standard, you have it in your finances, the degree. This is the slide that summarizes what I told you. So the first thing that a human being, feeding, grooming, transfer, the last thing that you have is bladder continence, that's a neurological process. We lose those things backwards when we get the dementia. So you usually become incontinent, and then you lose your feeding ability. I'm not going to touch in the cognition. You hear the best person you ever will have, which is Don Royal and Jason Chillingham. But basically, we do this. I usually ask you to do the club yourselves, and we have found that you will probably did that already with them. So I'm not going to do that. Useful questions, that I usually tell my trainees. I don't want that you come and tell me the family says that the patient has memory problems. How many of you have memory problems? Okay. Are you demented? No. So you need to go in detail, and these questions are just cues for you and to adapt it to what you're doing, your disciplines, and add more and get to know your patients. The depression scale, I think you spent some time already, but it's a standard in my office. How we use it, we have a standardized bilingual form. That's, again, I stress because where we are, that we need to be culturally competent. We need to have people that interpret it to our conversations, people that can be able to give us reliable information, and if there are very sensitive issues, we should get somebody that can help us with the language barriers. And Google, let me give you the story. Google is great. I have a Chinese elderly that moved a year ago to town. The daughter has been here only 5 years, and she came with a pain in the foot, and it was plantar fasciitis. Have you heard plantar fasciitis? So it's problem irritation in the tendon and the fascia, they're very painful. So I'm spending 45 minutes with the family trying to tell her about plantar fasciitis. Chinese, I speak Spanish, I'm very good with body language. I remove my feet, I remove her shoes. She looks at me very kind and very respectful, but doctor, I don't know what you're saying. So I'm getting desperate. I cannot talk about treatment when the patient doesn't understand the disease. So I said, Google. So I went to Google, opened the computer, put language preference, put Chinese, English Chinese, and I put plantar fasciitis. And then suddenly all of this Chinese stuff came. Of course, I didn't know what was it. But I saw a picture that looks very close to what plantar fasciitis is. And I showed to the daughter and the patient. They look at each other, they laugh, they hug me, they kiss me. They understood what I was saying, and I was able to move on. So technology these days can help. You have done it with French patients and diabetes. So you need to become creative to really break the barrier. Otherwise, you're not effective. You know. So I try to do my best, but I really don't think I'm that gifted to speak so many languages. So you need to see who is around and where you work. You know, people that work with Vietnamese immigrants need to, you know, get some fluent in some Vietnamese. I mean, that's part of the challenge in healthcare. I'm going to talk about this in the multidimensional because it's part of the physical exam. So let us do a little bit of the full risk assessment, and I need a volunteer, please. Somebody that is really very confident or something that can be confidential.
I'll be the old person.
You want to be the old person, Trish? Actually, AJS did a full campaign in Washington. Have a seat, Trish, thank you. And they did a full screening in Washington. I don't know if what the Congress House or White House, but it was really good, you know, to raise the awareness of the falls. So Trish, we're going to just play a role play very shortly, okay? You're just going to follow, you know, I'm your doctor, and you're just going to follow what I'm going to ask you to do. So Trish, please just cross your arms and please raise from the chair. Very good. Put your hands down and walk there until that corner. Very good, very good. Wonderful. Please observe her gaze. Somebody counting how many seconds? Turn around. Look at that turn around. Very good.
Wow.
Okay, that was a little bit hard. Have a seat. Very good. Comments about the performance. Anybody check how many seconds?
7 seconds from here.
So 7 seconds, and said that we lose 2 because I asked you to count. So 7, you actually were counting it before I asked you to count.
No, I counted from here back.
Okay, so 14 seconds around that. Okay, very good. What did you notice? So we're going to criticize your, okay, this okay. Any comments? So the arms,
Did not move.
the arm swing wasn't that smooth. Very good. What else?
She got up on assistant.
Exactly. She was able to get without using her arms. One attempt. That's very good.
Okay.
What else? That's good.
Did she do a misstep coming backwards?
Yes, and you notice that and you didn't see it. You usually want a flat surface. She was actually walking where the floor meets the carpet, but she catch herself. But you notice that, very good. So she had a little bit of problem, but she was able to compensate for that. What do you think about her 360 degrees? So fairly good, you know, she did it in block, but she only took 3 steps here to do. Trish, thank you so much. You can go back and I will continue. Thank you. Please stay good. You don't want a rolling chair, you want a hard chair. And you want to ask them to cross the arms or just ask them to don't use the arms together. And you're going to see people that are going to have really hard time and tell you, doctor, I cannot get up, I need to use my arms, so then you can allow them to use the arms. You're going to have people that in the posture, they're going to have probably stroke, so you need to observe how they are. And after they do, you ask them to walk around 10 feet, 6 meters, turn around in 360 and come back. That information will give you a lot of stuff. Do they go in one line? Do they deviate? Do they have a rigid posture and they have difficulty? Did they take more than 10 steps doing the 360? So it's a beautiful, easy test where you get a lot of information. And if somebody takes over 20 seconds to do this task, you need to do further evaluation because it's predicted of high risk for falls. A normal one is less than 10, and 10 to 14 is borderline. You know, so it's a very useful test. Doesn't take time. It's not expensive, and you can really rely on information to say, wow, something doesn't work well. The other thing that you can do is the tandem test, which is basically you ask them to be in front of you, and you want them to put one foot in front of the other. and you tell them to please don't touch the table anymore, and you should be able to stand for 10 seconds with one foot in front of the other. I only have had 2 patients that have passed that in the past, 7 years of practice. So it's a very predictive test that they usually just can't do. They are not able to compensate fast, so you need to look their feet. That's another area that geriatricians really, we encourage people to look. We like to see the ears, the eyes, but we wanted to also examine the feet. Little story, patient with dementia comes with the son who is the primary caregiver, moderate dementia. She's still, helping with some of her personal care. She stopped walking, so he brought her. And I removed her shoes, and she got the longest toenails I've ever seen, and they were already going under. And she's demented, she couldn't tell. So we trimmed the nails, the toenails, and she started walking again. So simple interventions in geriatrics take the function of the patient away. And that's the other problem when you do the physical exam and you see your older adults. These patients that have cognitive impairment won't tell you the regular things that we perceive as normal. Pain. I have seen people walking in broken hips for 2 days. People with abscesses, and they just do not behave typically. So we elderly patients just behave differently than your younger adults. The hearing and vision screening, having the SLEN in your pocket cards or having at the office, having a simple test, examine the ears. That's what I tell my trainees, did you check the ears? Many of the hard hearing impairment comes because you have impacted plaques. And cleaning those ears is what you need to do. Sometimes we use assisted devices for hearing called a packet talker. I'm Colombian, so I don't pronounce that packet like a packet. And a talker, you buy those things in Radio Shack for $30 to $50. They put it in their pockets, look at a little pager, and instead of having this, it goes here. And I have beautiful stories that I tell about these elderly patients that come to my office, and they just don't talk, so my residents come back and say, that resident is really demented. They didn't talk to me. Very demented, doctors. And I said, well, let me show you a trick. So I get my pocket talker in my office, I put it in, and they wake up and flourish and they start joking or tell me poetry or some connection that we have because they can hear. So never assume, that's another problem here, never assume anything about people until you are not sure. Never assume that somebody comes in a wheelchair and they cannot walk. They just came because the caregiver is in a hurry, got the wheelchair at the hospital and put it out. So those things are part of your physical exam. Never have assumptions. Even if you know the patient just got out of the hospital, ask them to get out of the chair. You wanted to be sure they can stand. You wanted to see how weak they are. So all of those pieces that usually, I'm not going to talk to you about the heart and the lungs, all doctors do that. But what we want in geriatrics is look into those pieces that nobody looks. Your feet, your ears, your vision. And a big one, your dentures. It's probably the most common disease around the world, cavity. And the GI tract with aging is slow now. But one of the biggest problems for elderly people to eat and have nutrition is if you have ulcers, pain, your dentures don't fit, they're not going to eat. So your physical exam focusing in the mouth is vital. I ask my elderly to remove their dentures. You won't believe what I have seen. I mean, you probably believe it. Things that the families don't even take. It's one of those parts that people don't look at it when they're caregivers. You can tell us stories, right? It's that you're like, oh my goodness, when was the last time that this person removed the dentures to clean? The same issue with the feet, with the ingrown toenails. The elderly is not eating, and we cannot find anything, but then you remove the dentures and you find why they are not. Abscesses, ulcers.
Always check your mouth and your tongue.
The tongue, cancers, pretty frequently, especially in a smoker. EA people can tell you they see those. So again, the physical exam in geriatrics is very focused on function and what else we can do, a good pair of glasses, a good pocket talker, the appropriate hearing aids, the appropriate assisting devices to help you to walk, rehabilitation, training, exercises, and the beautiful stuff that you could do for them before you can give up. And the other pearl is, if you hurt in your arm, not always is arthritis. I have so many elderly that cannot move anymore. The shoulder, they come to my visit, say, the doctor has been giving me ibuprofen for 3 years. They cannot move the shoulder. Put them in rehabilitation and they can brush their hair again and everything. So not everything is osteoarthritis. We have tons of diseases in the elderly that are rehab. So work in a team again. You know, well, I don't have all the answers. Well, let's see what the therapist says. Oh yeah, we did this and that. Now for power wheelchairs, I always need my physical therapist to help me because it became a Freud issue. Everybody wanted to get a power wheelchair, $3,000, write a prescription. It's actually helpful because if you really need one, we get it to you. But if you don't need one, let me rehab you. Let me see what it can do for you instead of just giving you a nice, cool power chair. You're going to become more sedentary. So there is a balance in what we do with geriatrics. Okay, let's see how we are. You train your staff. You don't have time. My staff does the vision and the hearing. We have a machine, a specialized machine, and they can test a little bit the hearing at the office. If not, work with a good audiologist and get a baseline and monitor them. But basically, these are services that in England are provided to the patients. Some of them are similar to what we have. Meals on Wheels, get support church groups, your podiatry, lunch clubs, respite care, a lot of things that the social worker help us in our interdisciplinary team to offer respite to the family, but also a good opportunity for these older adults to give some independence and meet their needs in the daycare, using money from Medicaid or private money if the families can afford it. I think you have a prevention talk, so I'm not going to spend a lot of time. But we do that as part of the visits too, right? Do you need your vaccinations? We always look into expectancy of life for a screening test. I mean, if you're 92 years old, you're very demented, bedbound, do we need a colonoscopy? No. So we talk to families. What are the goals of care? So maybe managing the pain is more appropriate than honoring a mammogram. So we always focus into goals of care, life expectancy. You know, it's not a driven care by money. It's but money and the resources as part of the decision making. You know, patients, Dr. Oaks, I'm 85. You know, I don't want any other test done. My doctor told me. I have a lot of doctors that told them you don't need anything. You negotiate with the patient and you respect that. You know, their decision. We're going to do a case together and we close and we're going to have a good lunch. This is a patient of mine, 72-year-old female, comes with the son and the provider, the daughter-in-law complains that she has been very moody lately, okay? Her son, Mr. G, reported that she has been a wheelchair bound for 10 months after a flood. The history was relevant for multiple episodes for forgetfulness and dementia that actually was diagnosed by a prior physician 2 years ago. Asking the family more details, they initially reported that these memory problems actually started 5 years ago. That's the famous question of, my mom has been doing great, but actually got bad last month. Well, actually, she has been getting bad for 5 years. But you need to get those questions, right? 5 years. Diabetic for 10 years, hypertensive, and arthritis and disease. Sound familiar, right? We have a patient like that. She took Geri-Assessment, which is a memory pill that we use. The second one took a very old in the market, pretty safe. They actually stopped it, and they noticed that she deteriorated when they stopped the Geri-Assessment. The physician prior me recommended an antipsychotic for agitation, but the patient went to be too sleepy and groggy, so the family was really nervous, you know. From being very agitated to not do anything, not even eating, for the side effects. Appropriate diabetic and hypertensive management and medications were okay. We reviewed them, they are fine. She takes an aspirin a day. Asking how much she was doing, this is what she did in her activities of daily living. She was able to feed herself, but only soft food. She needed assistance for thick solids, so cutting the meats, cutting the potatoes, everything needed to be cut. Need a lot of help with the dressing, totally dependent in the bathing, incontinent to urine for 1 year, and partially incontinent with bowels. Sometimes she will tell you to toilet, but sometimes she will have an accident. Her son and provider prepared the meals. She's so impaired in the ADL that her IDLs is not surprising. She's needing all the help already. Not able to transfer, neither walk anymore for a year, and the rest pretty much she needed complete assistance. Mrs. A is not able anymore to manage finances, cannot use the phone, but she can recognize her family members. She confuses sometimes the grandchildren as her children. And her main activity is watching TV. She scored a mini mental 21 out of 30 because she's highly educated. She was a professor at the university. She's probably more demented, but look at her clocks. Poorly done. She just couldn't perform the task. Neither way, neither the one, neither the two. And her geriatric depression scale 4 out of 7, pretty much. She's not depressed in other words. So the physical exam, she's very petite, wheelchair bound, pleasant, but totally disoriented, didn't know where she was when I examined her, didn't know it was a doctor's office even though I have a white coat. And when I brought her to see it's a hotel, an apartment, a doctor's office, she said it was a hotel. Even with the cues of being a doctor, she couldn't get. Positive findings, a lot of contractures in the lower extremities, mild generalized weakness. She didn't have focal deficit, meaning she didn't have a droopy face or she wasn't like a stroke patient. Follow a simple commands, and she became very angry when I tried to examine her legs and she couldn't stop. So as the team today, let us make a problem list on her. Or well, first of all, do you have any other questions before we move to the next activity?
Was that anger because of pain?
That's what I want that you tell me. So you start exactly where I want. What is your problem list? So your first problem list is this woman is in pain. Why she's in pain?
Because she doesn't want you to touch her.
She what, sir?
She doesn't want you to touch her legs.
And because she got the contracture, so when you move her, so she's probably in pain. Very good. What other problems do your assessment?
Caregiver burden, the question about the daughter-in-law and whether
So
she's...
they're coming not because she's moody, they're coming because they wanted to know this is going to get worse and what are we going to do and this is not pleasant. Exactly. So caregiver burden pain.
She only eats soft foods, so you wonder, like, is a problem pain in her mouth? She's not hungry? I mean, she has stomach pain or, you know.
Very good. And for the physical exam, it sounds like she's very petite. So she's having probably some weightless issues, some failure to thrive, and you wanted to do all of those things. Very good. So we have pain, we have caregiver burden, we have potential failure to thrive, weight loss. We cannot say that yet, but there is raising issues. What else? Incontinence, big issue. The majority of people, and you hear probably Don Royal saying, when patients become incontinent, that's the cutoff for families to place them. Because continence is another whole animal. The personal care of, and talk about incontinent, male son taking care of a female incontinent, very difficult. So yes, incontinence, and now it's not only bowel, that is not only urine, but bowel. Very good. What other problems?
I would look a little bit further into the issue of the diabetes and what her lab values were, because that could affect her mindset and how she's dealing with the food she eats, and if that's managed.
Very good. And maybe the lady is so hypoglycemic all the time, she gets so agitated, or her sugars are so fully controlled, she gets agitated. So the agitation related with these inappropriately, managed diseases, or there is something else going on. Very good. What else?
The medications too.
The heart medication. Review her medications again. Is there anything new? Have we done any changes? Have we established? She gets too sedated with antipsychotics, but there are other we don't think so. Very good.
And
What
that
about?
might be bothering her digestion too.
Many of those medications that will help you to eat, tidying up to the eating. So review the medications. Very good. Okay, we need to move on. But wonderful. So you came with a very good assessment of all of these things required. More detailed assessment. We didn't talk about more the contractures, but that's a big issue. This woman is wheelchair bound for 10 months. And can we help her or not? So let us talk about what you're going to do. So the Geri-Assessment, we did it. And we found that we combined all the elements of the evaluation to come with a common plan of diagnosis of care. And what we did is the increased agitation in advanced dementia with behavioral problems versus delirium. So we needed to get tons of labs, including the urine, the white count, electrolytes, and all that stuff, to really see if there is this coming. The diabetes stuff was added to that. Tons of the conditioning, correction, the fact that she needs full assistance. Albumin storage levels were ordered. We got a nutritional consult, look into the finances to see if they could afford some supplements appropriate for diabetes care, how much she really keep a diary of what she was eating, what she likes to do. We examined her mouth, we got her a dental referral. The caregiver issue was vital. They were getting tired. So we asked for a human resources letter to get a provider. We sent home health to do diabetes education, managing the medication, see how many other medications they maybe were giving her that families sometimes, they think that the patient can manage medications and they just will have, I have patients that hide medications under their mattress. And they are delusional, so they take extra pills of that. So examining the house, the full assessment was done. She got contractions, but they start doing PTOT at home with the home health, looking into hazards, putting light at night. Tons of incredible stuff to really help this family. Yes, ma'am.
Do we, in the community, provide respite care for families?
Yes, there are a lot of resources that you can do for respite. The majority of them are private pay. But you can definitely get vouchers. Like Homewood residents will give you a voucher as a marketing strategy, and you can leave your family member for a few days with them, and if you like the facility, they will give you a discount and you can place them there. The VA covers a lot of other respite in the local nursing homes. There are nursing homes that you will pay reasonable amount per day, and you could do it. The Catholic charities can help you to get resources in terms of respite. And we talk about respite, not necessarily in leaving somebody somewhere, having friends from church twice a week, so the caregiver can get out and have a cup of coffee, a lunch with a friend. What about family members from outside that can say, when they are not that demented, can you come and give me a weekend? I actually tell my caregivers, leave the city. If you stay in the city, remember to have vacation. Go and do something fun, you know, bring your siblings, you know, twice a year, family member, relatives. Get your social workers, get the social worker to the home health to help you with the resources. Having a provider that can come 3 times a week, 4 hours a day, can give you respite to go shopping at the grocery store. So we need to become creative because, again, more and more we have a lot of undeserved people, people that don't have Medicaid or Medicaid. So what else can you do in your community, in your cultural group to do that? And we did a follow-up agenda. So basically, she received the comprehensive education about dementia, the prognosis. We modified the medication, the caregiver network initiated, PT, I told you all the stuff. We did the advanced directives. She's not doing good. She broke her hip. She's very advanced in her dementia. Do you remember what she wanted when she was younger? Did she ever say, hey, I will never wanted to have a ventilator? No, her, but maybe because her husband died in a ventilator. Or maybe she saw one of her best friends and she said, I never wanted that. So even though you need to ask families, you ever hear your mom when they say, no, 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 a friend, you know? And I mean, there are a lot of ways that you're social workers and you can do it as a team. And pretty much the take-home points. These assessments are great. They can be easily done when you have a right context, but in your specialties, just be aware of these kind of pearls and use it in your families and how you coach other patients and people in the community what things should be checked. Just by carrying a phone, how many of you have friends that have elderly parents? You check, you know, sometimes that's what we need. Geriatrics that can be applicable to any lay person in the community. So we do a better care for all of you. Any questions?
What is that?
It's a big, gigantic stethoscope. So she can hear better. Actually, I have used a couple of times when I didn't have the packet talker. Sometimes it can help you reverse the situation. Any other questions or comments before we close?
Thank you.
You're welcome. Who's taking me for lunch today? Thank you guys.